So we're going to give you 60 seconds each to run through yourself, who you are, a little bit about your company and opportunity. And again, maybe your superpower if you want to do that.
I'm John. I'm the co-founder and chief medical officer of Flosonics Medical. My background is pulmonary and critical care medicine. Um, what we've done at Flosonics Medical is we've developed the world's first wireless wearable Doppler ultrasound system. I think it's a very elegant solution because it looks at both the right heart and the left heart simultaneously down through the neck. And our superpower right now is helping sepsis resuscitation, giving the right amount of intravenous fluids in sepsis. It has a bit of a Goldilocks principle. You don't want to give too little, and you don't want to give too much because there's complications from both. So we've been used on just about 2,000 patients now to help gauge sepsis resuscitation in that regard. Because there's a very high incidence of both acute systolic and diastolic cardiac dysfunction and sepsis. We've also accumulated a database of many millions of cardiac cycles that's going to help us fingerprint and phenotype cardiac pathologies moving forward. We hope to help prognosticate early sepsis and then beyond the inpatient realm into the outpatient realm using AI-enhanced algorithms.
Summarize the key message that you would tell in this very short period of time you have of your clinical and economic value propositions, and make sure you tell us if you're reimbursed or if you're just an enterprise sale that's going to just fit into the overall economics, and explain that business model. So it's really ultimately business model that we're kind of going after here, as well as the benefits.
We've been on just about 2,000 patients now, and I think what really comes to mind is just a recent story of resuscitation that where our device was used to help facilitate the best efficient, the best care, the most cost efficient care. And it was a very young man in his early 40s that sustained a traumatic brain injury, was completely bedbound, in and out of the ICU recurrent bed sores, recurrent infections, recurrent pneumonias, had a feeding tube, was chronically mechanically ventilated through tracheostomy. And he showed up again in the emergency department with signs of brewing sepsis again. It was severe sepsis. So he had some organ dysfunction. He had a severe infection. It was thought to be a pneumonia. But he also had really known poor cardiac function. He just had a history of very bad cardiac disease. He had known ejection fraction of less than 20%, and normal's 60% or above. And his blood pressure was low, but the physicians in the emergency room were just really reluctant to give any intravenous fluids because they knew how bad his heart was, and they didn't want his lungs to fill with water. They didn't want him to have a prolonged course on mechanical ventilation. His family didn't want him going back to the ICU because he's been in and out of the ICU recurrently. It's a strain on the family. So the nurse put our device on, and in less than 2 minutes, they knew that his right heart looked good. They knew that his left heart looked good. They did something called a passive leg raise. They saw that his heart responded appropriately would respond appropriately to intravenous fluid. So they gave him intravenous fluids, even though kind of all of his medical history pointed to giving no fluids. They were ready to put central lines in them. They were ready to start him on inotropes. The cardiologist was there, but what our device did was it gave the emergency room physicians confidence to resuscitate that patient with intravenous fluids. He didn't even have to go to step down. They saved him the central line. They saved him the inotropes, the vasopressors. They saved him an ICU stay. So severe sepsis with mechanical ventilation for more than 96 hours, the hospital gets $42,000, and they get that amount of money to distribute their care. So the price of our device, they were able to claim that DRG and deliver care at a fraction of the cost. So there's a very strong financial model for allowing hospitals to deliver efficient care, save money out of the DRG. But I mean, honestly, most importantly, it's just keeping that guy out of the ICU that didn't need to go to the ICU is the real value prop for our device.